Okay, so you're cardiology coder in 2024,
Mm.
and wham, new codes. We're going deep on these 2024 cardiology coding updates today. Gotta stay ahead of the curve, right?
It's true. These updates are really about new ways we think about heart health.
First up, CPT changes. And there's one that caught my eye, a new code for non-invasive FFR. Is this going to be a big change from a coding perspective?
Yeah, definitely something to keep an eye on. So that invasive procedure code, that's 76998, that one's here to stay, at least for now. But this new non-invasive code, 75580, this is a big move towards being more cost-effective and patient comfort. Be ready to see these cases more often and understand, like, the documentation differences between the new and old procedures.
So we have to know the new code A and D, when to use it. What kind of documentation would be a red flag for you?
That's the key. The documentation has to show why they chose non-invasive FFR. Like, if the patient is a good candidate for less invasive stuff, or maybe even cost as a factor, if it's documented right.
So much more to it than you'd think. Okay, next up, epicardial ultrasound. New codes for that, 76984, 76987, 76989. But I need you to paint a picture for me. What are we talking about here?
Okay, so picture open heart surgery, right? And they need real-time imaging right on the surface of the heart. That's epicardial ultrasound. A big jump in how precise and safe these complex surgeries can be.
Wow, that is impressive. So how does this work for coders? What are they looking for in the docs to make sure they code these procedures right?
Specificity, that's what matters. Look for descriptions of what the ultrasound showed, the structures they saw, and how that info changed how they did the surgery. The documentation needs to show why they needed this really complex imaging.
Gotcha. Now we've got new venography codes too. These
Mhm.
are 93584 through 93588. These seem really focused on congenital heart defects. Are we
Yeah.
seeing more of these cases, or are we just getting more specific with the data?
It's kind of both. We are seeing new ways to diagnose and treat congenital heart problems in kids, and that means we need more specific codes. These new codes let us keep up with those new treatments and how they're helping patients.
So coders need to pay close attention to the documentation and use these new, more specific codes.
You got it. If they use a description that's even a little bit off, they might end up using a broader code that isn't as accurate, and that wouldn't show how advanced the procedure really is or how much progress we've made.
Speaking of being precise, let's talk about those EM code revisions. They always seem to get people talking. What's the most important change we need to know about?
They got rid of the specific time ranges for codes 99202, 99205, and 99212, 99215, and that's a big deal. It means they want us to focus more on how complex the medical decision-making was, not just how long the appointment was.
I'm all for focusing less on the clock, but won't this make documentation trickier?
It does mean that the documentation needs to be super clear and detailed so we can justify which EM code we choose. Coders will be looking for documentation that clearly lays out how complex the case was, how many diagnoses were considered, how risky it was, all that.
So coders need to get those detective hats ready, because those EM cases are going to need some serious deciphering. Moving on to something I think is way overdue. Codes for caregiver training. These are 975501, 97551, 97552, finally recognizing those unsung heroes.
I know, right? These codes show how important caregivers are and give us a way to keep track of their training and support them. It means we're starting to see healthcare in a more holistic way, looking beyond just what happens at the doctor's office.
Which is amazing. But what exactly counts as caregiver training under these new codes?
It's a wide range of training, from the basics, like helping with daily life stuff like bathing and getting dressed, to really complex medical stuff like managing medications, wound care, even using special medical equipment.
So coders are going to have to stay on top of their game to make sure they're applying the right code for the specific training.
Yep. Look for documentation that spells out exactly what the training covered, how long it was, who did the training, and what the caregiver's role is in the patient's care plan.
Great points. Okay, we've tackled a lot with the CPT changes, but we're not done. Ready for the ICD-10-CM updates?
Hit me with it. This year's ICD-10-CM updates have some curveballs, I'm not going to lie.
All right, let's jump right in. One of the first things I noticed were those parent and kid codes. I'll be honest, the first time I saw those, I was so confused. How did you get your head around them?
It's all about being super specific, like drawing a really detailed map of all the possible diagnoses. The parent code is the general category, like a region on a map. Then the child codes get more and more specific, like the cities in that region.
Okay, that makes a lot more sense. So instead of just saying someone has angina, we can get specific, like is it connected to something like coronary microvascular dysfunction? And that's code I20.81, right?
Bingo! We need this level of detail for research, to figure out the right treatments and to track how patients are doing over time.
So coders really need to pay attention and not just use that broader parent code out of habit.
You got it. They've got to be on the lookout for any mention of coronary microvascular dysfunction, weird stress test results, or imaging findings that mean they should use that more specific child code.
It's like, where's Waldo? But instead of Waldo, it's the most accurate code.
Okay.
And since we're talking about finding things, there's this new code, I18.0, for resistant hypertension. I mean, hypertension, that's everywhere. But what makes resistant hypertension special enough to get its own code?
You're right, hypertension is crazy common, but resistant hypertension, that's a whole other thing. That's when someone's blood pressure just won't go down even with a bunch of meds. It's a nightmare for both patients and doctors, and we need a more targeted way to handle it.
So it's not just about knowing if someone has high blood pressure. We need to know the type and how bad it is, and that changes the treatment and how we keep an eye on them.
Exactly. And having this new code lets us keep better track of how common it is, if the treatments are working, and any problems that pop up. We can get a much clearer picture of this specific condition now.
Like we're painting a more detailed picture, right? And keeping with that idea, let's talk microvascular dysfunction. New codes for that, too, I25.85 and I21.B. Honestly, this was new for me. What's the key takeaway here?
So cardiology has been laser focused on those big blockages in the major arteries, right? But turns out problems with the smaller blood vessels, those are called the microvasculature, those can be a huge deal even if there aren't any obvious blockages.
So like little road closures all over a city can cause major traffic jams, even if the highways are fine.
Exactly. And when it comes to the heart, those little vessels, they're delivering oxygen and nutrients to the heart muscle. If they're not working right, it's a big problem.
So that's where these codes come in. I25.85 for chronic coronary microvascular dysfunction and I21B for myocardial infarction with coronary microvascular dysfunction.
You got it. Now we can diagnose and keep track of microvascular dysfunction better, and hopefully that means better treatment down the road.
Coders need to keep their eyes peeled for documentation that supports a microvascular dysfunction diagnosis.
For sure. Things like abnormal stress test results or imaging findings that point to microvascular dysfunction. Without those specifics, it's easy to default to those broader codes and miss the boat on capturing what's really going on.
It's mind-blowing how a tiny word change in the coding world can mean a huge shift in how we treat heart health. Now, on to some code revisions that might seem small, but are really important for coders.
Yeah, sometimes it's those little language tweaks that make the biggest difference in coding, right?
That's what makes these deep dives so cool. We get to go beyond the surface and really nerd out on the details that really matter. So what's first on our list of small changes, big impact?
Okay, let's talk about the tiny change to the code description for atherosclerotic heart disease of the native coronary artery with refractory angina pectoris. They swapped out an S for a T.
I have to admit, when I saw that, I thought it was a typo. But you're saying one letter really matters.
It's crazy, but yeah, it shows just how much precision matters in medical language, especially for coding. Even what looks like a small detail can totally change how we analyze data, what we find in research, and even how we treat patients.
Coders, time to channel your eagle eyes. Every single letter matters. Okay, how about those aneurysm code revisions? Those seem to be causing some debate.
The main change is that they're switching out abdominal for thoracoabdominal in the descriptions for a few aneurysm codes, specifically I71.51, I71.52, I71.61, and I71.62.
So for aneurysms in the aorta, that's the big artery. The new wording shows where they are more accurately.
Yep. Thoracoabdominal is more accurate because these aneurysms often stretch across both the chest, that's the thoracic part, and the abdomen.
Okay, so what does this mean for coders in their day-to-day? How do they make sure they are using these updated codes correctly?
They've got to really look at the documentation and pay attention to where the doctor says the aneurysm is. If it says anything about the aneurysm being in both the chest and belly, that's the clue to use those updated thoracoabdominal codes.
So once again, it's all about the details and the documentation. Speaking of details, let's move on to the part that's always full of them, Category 3 CPT codes. For anyone who's new to this, what makes these codes special and why should we care about them?
Think of Category 3 codes like the experimental lab of medical coding. They're where we test out new technology, services, and procedures to see if they're ready for prime time. They're like temporary codes. They might become permanent or disappear if the procedure doesn't work out.
So it's like a sneak peek into the future of cardiology. We get to see what innovations become the next big thing and what fades away.
You got it. For coders, these Category 3 codes are super important because you're the ones tracking all these new procedures and technologies.
Which means we always have to be ready for anything. So what got you excited in the Category 3 section for 2024?
Get ready for this wireless pacemakers and leadless pacemakers. This is some seriously cutting-edge tech that's changing how we manage heart rhythms.
Okay, I gotta admit, those sound like something out of sci-fi. We're talking about tiny devices that go directly into the heart, no wires needed. Technology is amazing.
It really is. And that's why we need a coding system that can keep up with all this new stuff. That's where those Category 3 codes come in. They let us track these new technologies as they come out and see how they work in real life.
So coders, you gotta get to know these new technologies and their Category 3 codes. Be ready for those claims.
Totally. And it's not just about memorizing the codes. You've got to understand the procedures, what their benefits are, and what the documentation needs to say.
It's about being more than just a coder. It's about being a go-to expert for the clinicians and a real part of the patient's care team.
Couldn't have put it better myself.
No.
Now, before we get too carried away with these futuristic technologies, let's talk about the codes that didn't make it.
Oh yeah, like anything else, some codes are going to bite the dust or get absorbed into other categories. It's the circle of life, coding edition.
Truth. This year, we're saying goodbye to codes 0501T through 0504T. Those were for a specific type of non-invasive FFR that used computational fluid dynamics.
So that method didn't quite catch on enough to get a permanent CPT code. It's a good reminder that even in medical coding, which seems like it should be clear-cut, there's always some wiggle room. We're always evaluating and adapting.
Yep. New technology pops up. We learn more about heart health. We got to roll with it.
And that's why these deep dives are so important. We got to stay ahead of the game and be ready for anything in this constantly changing world of cardiology coding.
That's what makes our job so interesting. Always learning something new, tackling new challenges, and finding new ways to help patients get the best care possible.
And speaking of finding new ways, we've talked about the CPT changes, the ICD-10-CM updates, and even those super cool Category 3 codes. But there's one more thing we can't forget about with these new codes: documentation.
So true. All these code updates, with all their details and quirks, they're only as good as the documentation that backs them up.
So let's switch gears and talk about what these updates mean for the people on the front lines, the doctors, the coders, and everyone who makes sure these codes actually translate into action.
You know, it's funny, we talk about these codes, but they're really telling a bigger story about how we're understanding and treating heart problems these days.
Yeah, like each code is a piece of a huge puzzle, and by putting them together, we get a better picture of heart health overall.
I like that, the puzzle analogy. And speaking of puzzles, we got to talk about documentation.
Right, because if the codes are the puzzle pieces, good documentation is what holds it all together.
Exactly.
So for our listeners out there who are up to their eyeballs in patient charts and coding manuals, what are some documentation red flags to watch out for with these 2024 updates?
One of the biggest ones, especially with the EM changes, is that we're moving away from just using time to code and putting more emphasis on medical decision-making.
Right, we can't just look at the clock to figure out how complicated a case is anymore. So what should coders be looking for?
They need to look for documentation that really tells the story of what's going on with the patient. What were the problems they came in with? How many different diagnoses were considered? Were there any risk factors? What about potential complications? The documentation needs to back up how complex the decision-making was for that visit.
It's like those choose-your-own-adventure books. But instead of picking an ending, we need documentation that explains all the different options they thought about and the medical reasons behind their decisions.
Exactly. And that level of detail is super important for getting paid the right amount and avoiding problems down the line.
So coders, time to channel your inner storyteller. The more detailed and engaging the documentation, the easier it'll be to pick the right code and get those claims paid without a hitch.
Couldn't have said it better. Okay, let's talk about those new parent and kid codes in ICD-10-CM. I've heard some coders are feeling a little overwhelmed with how much more specific these codes are.
I could see why. It's like switching from a regular map to one that suddenly shows every little back road and side street. You need a magnifying glass.
And a whole lot of attention to detail. Like, take those new codes for angina pectoris. We're not just coding for angina anymore. Now we need to get down to specifics, like, is it related to coronary microvascular dysfunction? That gets its own code, I-20.81.
So coders need to really look closely at those physician notes and make sure they're not just defaulting to the broader parent code because that's what they're used to.
Right. They've got to be on the lookout for any mention of coronary microvascular dysfunction, any unusual stress test results, or anything from the imaging that points to using that more specific child code.
It's all about putting those documentation clues together to get to the most accurate code. And speaking of connections, let's talk about microvascular dysfunction and its new codes, I-25.85 and I-21.B. This feels like a big deal because it's highlighting a condition that might have flown under the radar before.
It really shows how these code updates reflect how our understanding of heart health is always evolving. For the longest time, we were all about those big blockages in the main arteries. But now we get at problems with those smaller blood vessels, those tiny little roads on our heart maps. Those can be just as serious, even without those big, obvious blockages.
So it's like, even if the highways are clear, a bunch of small accidents on the side streets can still cause traffic nightmares.
Exactly. When it comes to the heart, those small vessels, they're the ones delivering oxygen and nutrients right to the heart muscle. If something's wrong there, it's a huge problem.
And that's where those new codes come. In I-25.85 for chronic coronary microvascular dysfunction and I-21B for heart attack that happens along with coronary microvascular dysfunction.
Exactly. Now we can diagnose and track microvascular dysfunction more accurately, and hopefully that means we can create better, more effective treatments.
So for our coder friends listening, keep microvascular dysfunction in mind and know what to look for in the documentation to support using these new codes.
Absolutely. Look for anything specific, like unusual stress test results, anything weird with coronary reactivity testing, or even findings from imaging that point to microvascular dysfunction. Without those specifics, it's easy to just use those broader codes and miss what's really going on.
It's wild how a seemingly small word change can make such a big difference in patient care and how we analyze data. And speaking of small but mighty changes, those revised aneurysm codes we talked about earlier, the ones where abdominal got swapped for thoracoabdominal, those really show why those details matter.
For sure. It's the perfect example of how using the most precise medical language possible is so important, especially for coding. That one word change gives us a much more accurate picture of where those aneurysms are, since they often cover both the chest and the belly.
So coders really dig into those operative reports, imaging studies, and physician notes to pinpoint exactly where that aneurysm is.
Yep. If it says anything about the aneurysm stretching into the chest, that's your sign to use those revised thoracoabdominal codes. I-71.51, I-71.52, I-71.61, and I-71.62.
It's like being a medical detective, piecing together the clues from the documentation to crack the case of the most accurate code.
Love it. Speaking of detective work, let's move on to the Category 3 CPT codes. This is where things get really interesting because we get a peek into the future of cardiology and the coding that goes along with it.
Hit me with it, I'm ready. What kind of futuristic stuff has caught your eye?
We've got some seriously cool things happening in cardiac rhythm management. Wireless pacemakers and leadless pacemakers are all the rage right now, and for good reason.
Okay, I have to admit that sounds straight out of a sci-fi movie. Tiny devices that go right into the heart, no wires needed. That's amazing.
It's pretty incredible how far we've come. And this just shows why our coding system has to keep up with all the new technology. That's where Category 3 codes come in. They help us keep track of these new things as doctors start using them more and more so we can see how they're working.
So coders, get ready. You want to be familiar with these new technologies and their Category 3 codes so you're prepared when those claims start coming your way.
Exactly. And don't just memorize the codes. You've got to really understand the procedures themselves, why they're good, and what needs to be in the documentation.
It's about being more than just a coder. It's about being a resource for the clinicians and a real part of the team that's taking care of the patient.
Couldn't have said it better myself. Okay, before we go too far down the rabbit hole of futuristic technology, let's talk about the codes that didn't make the cut.
Right. Just like everything else, some codes are going to disappear or get lumped in with other categories. Circle of life, coding style.
So true. This year, we're saying farewell to codes 0501T through 0504T. Those were for a specific kind of non-invasive FFR that used computational fluid dynamics.
So that particular method didn't gain enough traction to earn a permanent spot in the CPT code set. It just goes to show that even in the world of medical coding, where things often seem so black and white, there's a lot of gray area, and we're constantly evaluating and adapting.
Exactly. New technology is always popping up. We're always learning more about the heart. We got to stay flexible and roll with the punches.
And that's what makes these deep dives so crucial. We have to stay ahead of the curve and be ready for anything in this world of cardiology coding that just never sits still.
That's what keeps our jobs exciting. There's always something new to learn, a new challenge to tackle, and at the end of the day, a new way to make sure patients are getting the best care possible.
It's wild how these codes, even tiny changes, can get us talking about the future of cardiology like this.
It just shows how much is going on in this field. We're not just coding for what we do now, we're coding for where things are headed.
I love that. So like each code gives us a little peek into these amazing advances in how we're treating the heart.
Mm.
And for those of us who work with these codes every day, it means we have to do more than just memorize a bunch of numbers and letters. We have to get the why behind them, understand all the documentation details, and see how it all affects patient care.
Absolutely. It's like being part detective, part storyteller, and part lifelong student all at the same time.
Okay, I'm stealing that detective, storyteller, lifelong learner. That is the perfect description of a coder. And speaking of lifelong learning, what's your number one piece of advice for our listeners as they're tackling these 2024 cardiology coding updates?
Don't be scared to just dive in, ask questions if you need to, and embrace the challenge. I know these updates can seem a bit intimidating at first, but really they're all about making patient care better and getting a clearer picture of what's going on with heart health.
It's about moving away from that just check the box way of thinking and really understanding each case, each code, each little change in the wording. And that's where working together becomes so important, right?
100%. We need open communication between everyone involved, the doctors, the coders, the auditors, everyone on the patient's care team.
Because at the end of the day, we're all on the same team. We all want the same thing, better care for patients. And that starts with accurate and insightful coding.
Exactly. When we all understand each other, when we're all committed to learning and working together, that's what makes the real difference.
It's about being able to speak the same language, a language that's precise and detailed, a language that shows we care about heart health.
Couldn't have put it better myself. That's a great place to wrap up, I think.
I think so too. So, to all our listeners out there, thanks for joining us on this deep dive into the 2024 cardiology coding updates. Stay curious, keep your coding skills top-notch, and never, ever underestimate how powerful a well-chosen code can be. Until next time, happy coding, everyone.